Okay, let's dive right into this explainer. For the medical and graduate students joining us, you already know that understanding pulmonary function is absolutely foundational to respiratory medicine. Today, we're going to construct the spirogram from the ground up. We aren't just going to look at the final graph and memorize it, right? We're actually going to understand exactly how our lungs function by building it piece by piece, maneuver by maneuver. So, spirometry. It essentially serves as our primary window into respiratory mechanics, and it's a highly elegant yet beautifully simple, non-invasive test. Think about it. The patient is simply asked to breathe in and out of a mouthpiece, and from that single mechanical action, we generate a detailed graph plotting the precise interrelationship between lung volumes and ventilation over time. Usually, we're expressing these values in liters or milliliters per minute. It's literally real-time physiological mapping right before your eyes.
To make sense of all this data, we're going to build it logically. First, we'll hit the spirometry baseline. Second, mapping lung volumes. Third, calculating lung capacities. And finally, clinical diagnostics and disease.
Okay, Section 1, the spirometry baseline. Let's start with quiet resting breathing, which is really the absolute foundation of our graph. Before we ask the patient to do anything strenuous at all, we typically start the test with the subject just putting in the mouthpiece and breathing in and out quietly. They're just sitting at a resting level. As they breathe in, the graph goes up. As they breathe out, it goes down. It's just a continuous, gentle cycle of in and out. This simple, resting state establishes our baseline metric.
Now, what's really fascinating here is that this quiet, resting breath has a very specific volume associated with it. We call this the tidal volume. In a typical resting person, it measures at right about 500 milliliters. So every normal breath is moving about 500 milliliters of air, representing the standard baseline efficiency of our pulmonary system without any extra exertion.
But I want you to contrast that immediately with another totally vital metric. 1,000 to 1,200 milliliters. This is the residual volume. You see, even if you were to force out absolutely as much air as you possibly could, there's still a volume of air that stubbornly remains trapped in your lungs. After a maximal expiration, that 1,000 to 1,200 milliliters just sits right there, ensuring the lungs never completely collapse. Keep that specific volume in mind, okay? Because it's going to be absolutely essential for our calculations a little later on.
Moving on to Section 2. Mapping lung volumes. Let's see how this whole picture builds when we push the patient's respiratory system away from that quiet baseline and really test its physical limits. This brings us to a highly important clinical action, the vital capacity maneuver. By coaching the patient through these exact steps, we capture some truly crucial data. First, we go from that normal resting tidal breath. Then, we instruct the patient to breathe in as much air as they possibly can, taking them all the way up to their total lung capacity. Then comes the critical part. We ask them to exhale as fully and forcefully as possible, pushing all that air out until there is literally no more air left for them to expire, dropping them right down to that residual volume we just talked about. This maneuver is an absolute game changer because it doesn't just give us total volume, it allows us to evaluate the specific rate at which expiration occurs, and that is a massive indicator of mechanical lung function.
All right, Section 3, calculating lung capacities. Now that we've mapped out those extremes, let's look at the actual math of lung function by combining these volumes together. Isolating those specific extremes unlocks our reserve volumes. On the inspiratory side of things, from the top of that normal 500 milliliter tidal volume all the way up to total lung capacity, we have the inspiratory reserve volume. That's the maximum extra air you can pull in. Conversely, the difference between a normal expiration and the absolute bottom limit is the expiratory reserve volume, the extra air you can push out. But listen, the most important clinical math happens right at the bottom of this calculation. We mathematically add the expiratory reserve volume to the residual volume. Together, they comprise a vital capacity known as the FRC, or functional residual capacity.
Now, why does this matter? Well, the crucial point here is that the functional residual capacity isn't just some mathematical abstraction for your board exams. It's actually a vital functional reservoir of oxygen. Because of the FRC, oxygen diffusion from your alveolar ventilation into your pulmonary capillaries doesn't just suddenly stop the second you start exhaling. No way. This reservoir ensures that blood remains continuously oxygenated between every single breath.
As future clinicians, you absolutely must recognize the vulnerability of this system. This life-sustaining FRC oxygen reservoir can be greatly altered by various manipulations in a hospital setting. Even simple changes in physical position can shift this volume. The administration of certain drugs, and especially the application of anesthesia, can severely alter this reservoir. So understanding the FRC really means understanding how easily a patient's baseline oxygenation can be compromised during their treatment.
And finally, Section 4, Clinical Diagnostics and Disease. Let's translate these curves into real-world tools for detecting lung disease.
Before we can even think about diagnosing pathology, we absolutely must have a reliable baseline, right? Spirometry is a fantastic first-line test, precisely because we have incredibly robust normative values. And these aren't just guesses. These values have been derived from testing thousands upon thousands of individuals. When you're looking at a spirogram, you are cross-referencing your patient's results against strict normative baselines dictated by three key things: their specific age, their gender, and their height. By comparing a patient against those normative values, we can immediately spot pathology. For example, when you look at the test results and discover a vital capacity that is much smaller than the normative baseline for that patient's age, gender, and height, well, you've just found a major diagnostic red flag. A significantly decreased vital capacity is often the very first major indicator of lung disease. For instance, in restrictive diseases like pulmonary fibrosis, you'll see this vital capacity shrink globally. On the flip side, obstructive diseases might show a massive increase in that trapped residual volume.
So, we've seen how vital capacity shrinks. But as you get ready to hit the wards, I want you to keep this foundational spirogram in mind. Ask yourself this: how will different pathological states, like obstructive versus restrictive diseases, uniquely reshape these exact curves? How exactly are they going to alter the rate of expiration, or trap more air in that residual volume? Understanding the normal spirogram is literally the first step in decoding the complex respiratory pathologies you are going to face as clinicians. Keep these charts fresh in your mind and let them guide your diagnostic reasoning.